I just want to thank you all for coming. I have not had a voice all week, so hopefully it will last through this presentation. But we really appreciate you participating in this event. We've had a lot of fun preparing it and hope that it's really practical and useful for you in your everyday practice. So I have the pleasure of running through a few cases with you. And this is just trying to put all the pieces together. And hopefully it'll take just a half an hour. Hopefully also, I'll turn this on, it'll actually work. Okay, our objectives, I'd like you to be able to answer common questions that come up in primary care about autism, to be familiar with the referral steps for autism-related concerns that are brought up in the primary care context, and also that you'd feel comfortable tracking comorbidities in your practice. So these are the three things. I don't have anything to disclose. We're talking about quarterbacking today, and the only thing I will disclose is that I'm really sad that Doug Baldwin's career is ending with the Seahawks. So if you're quarterbacking and you don't have a receiver, that's kind of a bummer. So, okay, so why, I'm going to step this way so I can actually read my slides because my eyes aren't good enough to read what I've printed. Why is ASD and developmental delay important in primary care? One of the things is that it's super common. 1 in 6 children have some sort of developmental disability. The prevalence of developmental disability has been increasing over the last 20 years. So the numbers from 2006, 2008 showed that it had increased 17% compared to the decade before. The prevalence of autism ballooned to 289%. This is probably due to a change in the diagnostic criteria as well as increasing awareness and increasing willingness for parents to bring their kids forward. TK has a great kind of 3-liner about that, but I won't spend a lot of time on it here. But for comparison, like the prevalence of ADHD in this time period increased about 33%. So I think there's more awareness of multiple kinds of mental health and interaction of mental health and developmental disability. Looking at other chronic diseases in childhood, asthma is prevalence of approximately 8%, ADHD approximately 11%, and autism is rolling at around 2.5% of kids. So why is primary care important to children with autism? So the reverse. Receiving care in a medical home or in a primary care setting where the provider is really engaged with looking into issues related to autism makes a huge difference for families with autism. There is a lot of associated trauma and stress in taking care of a child with autism. It profoundly affects the whole family structure. We see this in a number of studies. Children with ASD are 6 times more likely to have a family member who stopped work or spent more than 11 hours a week coordinating care. So going to ABA therapy can be 20 hours a week. It's a huge drag of time, and for a lot of parents, it's really hard to cut back on work. It's really hard financially on the family. The HCN is children with special healthcare needs. Even in that subgroup of children with special healthcare needs, kids with ASD were more likely to live in families that reported financial problems, needed additional income for the child's medical care, and reduced or stopped work for the child's condition. They were also twice as likely as typically developing peers to experience adverse childhood events. I don't know how familiar you are with the 9 adverse childhood events, but those have been shown to be predictive of development of chronic medical diseases in adulthood. And the more ACEs you have, the more likely you are, the higher your risk is of developing these chronic diseases. And kids with ASD, 10% of them encountered more than 4 ACEs in their childhood, including income insufficiency, neighborhood violence, parental divorce, mental illness, and substance abuse. And some of that mental illness and substance abuse is in parents, not just in the kids. Bullying is a huge issue too. It's reported 4 times more often among kids with autism than typically developing peers. All of these things are things that come up in your well checks. You talk about what's going on at school, how are transitions, how are things going in your life, do you have any problems getting food? All of these things are part of what we ask about in primary care and are really important to continue to ask about even in the setting of autism. Insurance and income seem to matter. The children insured by Medicaid have double the prevalence of developmental delay. I don't have a really good explanation for why that is, whether there's an issue with how we measure developmental delay, but that's the number. Children from families below the federal poverty level also had a higher prevalence of developmental delay, and low-income and minority children with autism experienced delays in diagnosis, significant misdiagnosis, and poorer quality care. So across the board, being poor with autism is really tough. And what makes a difference, though, in primary care? What are the things that you can do in your practice to really make a difference for these kids? Parents have identified that shared decision-making is really important in the process. These are complex kids. As we said, it affects their care affects the whole family system. And so discussing with the parents, what is their priority? What do you want to do first? These are the things that we need to address. How do we prioritize these so we do what matters most to you first? One of the things that matters to parents is more face-to-face time with their providers, so longer appointments. Now, this is really hard in primary care. We have, particularly if you work in a large system, you have a lot of pressure to see numbers of patients. We at Hope Central have decided that we wanted to have longer visits so that we could take on this care, so our shortest visit is 30 minutes. When we see a new kid with autism, we may take 45 or even an hour with them just to get the lay of the land. A lot of kids with autism can't be in the room for that long, so you have to balance it for what the parents need and what the kids need. Another thing that makes a big difference is case management, and this is something that in larger systems is a little bit easier to access. You may have a case manager if you're in a large clinic. For those of us in small, more private-style practices, this is really hard. It's very expensive. It's not reimbursed by insurance. We have the fortunate case that we'll be using some of this PSK money to bring a case manager on for our practice. But outside of grant funding, it's really hard to do this. But it makes a huge difference. So when we put all these elements together, this can actually help decrease hospitalizations and unmet health needs, but it may not completely decrease family stress, which is kind of interesting. One of the things that can affect the rate of diagnosis is proactive provider responses. So the more that we become familiar with the issues that families with kids with autism experience, and the more we ask about them, the more likely we are to start acting on those, and the kids are more likely to be diagnosed earlier. So even taking a little bit of time to come here today may make a difference in getting kids diagnosed earlier in your practice. So thanks for coming. A lot of times when we're caring for children with autism, it really feels like you're swimming upstream. You're kind of going against all of the parts of the system that drive you to see patients quickly, that drive you to not wait and listen. All the aspects of visits with kids with autism take more time. It takes more time to get their vitals. It takes more time to get the exam done. They're more resistant. That your exam may not be as good. It takes a while. It takes longer sometimes to build rapport with the child so the child is relaxed in clinic. All of these things take time, and it's really not, our system is really not designed for this. So good on you, stick with it, swim upstream. One of the things that we've done at Hope Central is adapted an annual questionnaire, and we actually use this more often than annually. The folks, Kristen Soul and the folks at University of Missouri have been very kind to share with us their interval assessment that they use in their clinic, and we kind of tailored it for a primary care setting. You have a copy of this in your resource folder, and we also, Tyler, who left, did a translation in Vietnamese for us of this form. This helps us go through autism comorbidities and give a chance for parents to rate where their kid is and how content they are with the services they're currently receiving. So this is super helpful for us to target the things that we want to talk about in a 20 or 30-minute visit. So if they're coming back for follow-up, this helps drive that follow-up. What's working well, what's not working well, what do you as a parent want to address first? And then it also allows us to check the boxes. Oh, we know what they're getting for physical therapy. We're still online for speech therapy and that sort of thing. One of the questions that I love at the bottom, which is hard to read here, But it's what has your child done well lately? What are you excited about? Again, trying to engage the parent around the positive things that are going on so they're not always thinking that things are bad when they have to come in. One of the things that we've decided is that we are doing every 3 to 6 months for rechecks, just an autism automatic recall. So if the child is closer to their diagnosis time, we're likely to do a 3-month recall. If they're further away and they seem to be pretty stable and going along pretty well, we may wait 6 months. But we at least see them 2 or 3 times between their well checks, or 1 to 3 times between their well checks. Okay, now we're going to have a little bit of fun going through some cases. This is participatory, so I want you all to speak up. We don't have to run and get the microphones or anything, but so speak loudly. If you can, just say who you are as you start to talk. That would be great. So here's the case number 1. A new family brings their 16-month-old into you to establish care. The parents are pleasant, but look totally exhausted. They report their child sleeps little and often refuses to eat anything except milk in a bottle. She has not had well care since 9 months due to a family move. What are you thinking at this point? Are you worried? Are you not worried? Yeah, go ahead. Great. Great. What else do people want to know, or what are you thinking? Okay, so daytime behavior, maybe what's their nighttime pattern of sleep? What does not sleeping look like? I often phrase it that way. I said, so what does not sleeping look like for you? And see what they say. Okay, so she has frequent tantrums, is not yet using mama or dada to refer to the parents. So there's your 2 questions, 2 answers. What else do you want to know? Oh, good. Is she growing? Good. Is she walking? Oh, yeah. Does she hold her own bottle? Good. Yes. Okay. Okay, great. So let's look again. Okay. Good. Yes, excellent. She hasn't been seen since 9 months. She probably missed her 12-month visit. There are a few vaccines there. We do need to keep track of that. So parents kind of volunteer that they are concerned that she stools only a few times a week, and she cries and struggles when she does. So it doesn't answer all your questions, but all of those things are great to think about. Sorry. Okay, so what do you think? Is her behavior in the range of normal? I hear concerns, multiple concerns around the room. Yeah, so interesting thing, clinical judgment only identifies about 30% of children with developmental delay. So our gestalt, although it may be good, doesn't catch everybody. So what do? We screen. So what is she eligible for at 16 months? What kind of screening could you do? Okay, I heard ages and stages, great. And the MCHAT, right. So the ages and stages, we use the ASQ3 at Hope Central. We also use the MCHAT-R. So you have a wide range of ages for the ASQ3. It captures multiple areas of development. So you have speech and communication, you have gross motor, fine motor, problem solving, and social emotional. There's also a social emotional ASQ, which we don't use. And the MCHAT, you could start at 16 months too. There is a 16-month ASQ, so you could choose either one of those for her current age. So what do you tell her about temper tantrums? So pretty common in this age, kids get frustrated, right? They can't communicate very well. If they have speech delay, those may be more intense. So we usually ask about triggers and timing and duration, but red flags, longer duration, increased frequency, persistence into older age ranges. If you have a 4-year-old that's throwing an hour-and-a-half fit in the grocery store when you say no, this is a problem, right? Something else is going on there. Also looking for specific sensory triggers. Ask parents, do you see patterns? Like what triggers, and is there a gradation of these temper tantrums? Or do some of them resolve easily and some of them derail the whole day? Also, tell me about sleep at this age. Are you worried with 2 nighttime wakings? Are you worried if she's sleeping only 9 hours a night? Are you worried if she's sleeping 30 minutes during her daytime naps? You just say yes or no. Yeah, so you could be. The two nighttime wakings may be a little bit on the high side for this age. Some breastfed babies will still get up to nurse, probably behavioral rather than need at this age. 9 to 12 hours a night would be your target sleep as long as they're getting those 2 naps a day. You'd like to see them sleeping closer to 12 continuous at night with 1 good long nap during the day. But there's some wiggle room there. Oh my gosh, you've already spent half of your appointment. What do you do next? We're going to follow Chris's advice and start a Miralax clean out and then decrease the dose after 4 to 5 days. Ask parents to cut down on the whole milk. Start serving it in a cup rather than a bottle to save your teeth. And then ask them to fill out the ASQ, which they leave in the waiting room because their child is done and really needs to go home. But they do show up in a month for follow-up, so they liked you enough to come back, even though you were asking these hard questions. And you're a hero, because all of a sudden her constipation got better, and her tantrums have improved, but just slightly. But she's still not sleeping much, and she refuses physical comfort during the day, and she prefers not to be snuggled, and is also not adding words to her vocabulary. So you're getting a few more red flags that indicate something is going on here. And finally, we get to the MChat. So you do an MChat in clinic, and there are 5 questions of concern. So where does that put you on the referral spectrum? At this age, you're good to do a few follow-up questions, but she's probably good for a referral as well. So where do you want to start? She's 16 months old. Where do you want to send her? Go ahead. Great. Birth to 3. Perfect. So the birth to 3 is done by zip code. So there you can Google birth to 3 and then the zip code that the child lives in, and it'll pull up the providers. You can call those providers and do a phone referral. You can give the parent the number. I would call the provider yourself and do the referral, because parents will put the piece of paper somewhere else, and depending on their embracing of the fact that their child may have a developmental delay, may not follow through. Child find for a child over 3 is related to the school system. So again, you can Google the school system and the child find. They'll give you a number you can call and do a referral there. They will call the family back. You can reassure families that in birth to 3, a lot of times they will do evaluations and therapies in the home. And so if parents are worried, I don't drive, I can't get there, my husband's at work all day, we can still do this evaluation. We can get this done. Another option is doing some individual community-based therapies. So say Child Find, you've called Child Find, they're on summer break, you know it's going to be 3 months before you can get anything in. So you can start with an audiology evaluation, you can start a community speech therapy evaluation. OT can help with sensory issues, begin to work with activities of daily living if this child is showing no interest in potty training or is having other things that are causing problems, just feeding. Feeding therapy for kids who are really eating only 2 things, that needs to be, you need to kick that into gear now so it doesn't get worse. And then if you want to do the autism evaluation, you know it's going to take about a year. Probably most places have between 9 months and a year wait unless they have commercial insurance. Commercial insurance has a variety of options. You can go to a neurologist, you can go to a psychiatrist, a psychologist, a behavioral pediatrician. And there are lots of options, and they're generally driven by the insurance. It's a little more limited with Medicaid. Medicaid kids need to be seen at a center of excellence to receive a diagnosis for ABA therapy. They can receive a provisional diagnosis through the school, so they can start getting school services right away. But to get additional medical-based services, they need to be seen at a centers of excellence. So that's a statewide program run by Children's, and we actually got a chance to participate in that. So Hope Central became a center of excellence, are we 4 years now? 4 years ago, and that's what launched us on this road that we're on now. And then Katrina is one of the family navigators at the Children's Autism Center, and she maintains a great referral list. And it's very long, so I don't have it in your folder, but we can access it, and we can send you a link to it in the follow-up information. Okay, so now you've got referrals under your belt, and the parents decline them all. Have you all ever run into this, where you know what to do next and the parents are not interested? Yeah, so I've had parents, it's taken me 9 months to convince them to go in for an evaluation, or even to go in for a speech or an audiology. These parents tell me that the child doesn't speak much because they let her watch TV all day, but they speak another language to her. Father says it's also because he's working really long hours. And you say, but I know that bilingualism doesn't slow kids down. I want you to keep speaking your heritage language to this child. But they do learn more if you speak to them face-to-face, if you play with them and not just let the TV do the talking. So you have a teaching opportunity there. And then you ask them to come back in a month so that you can do your 18-month well check. And then hopefully you'll get them to convince them to go see a speech therapist and get an evaluation, and maybe get some feeding therapy. Okay, so this is where I know we have a speech therapist here, and so you can jump in if you know other data. This is not my area of expertise, but expressive language in bilingual toddlers is really challenging, right? We don't have a lot of, I'm going to have to move fast. We don't have a lot of information about age-specific norms. Children exposed to 2 languages can distinguish those languages from infancy and develop 2 full systems, but there is some emerging literature that it takes longer to learn 2 languages to proficiency. What matters is more language. So more words, more communication from parents to children, as well as the time exposed to language. Even in kids with ASD, this makes a difference in language acquisition. So the amount of language exposure is the strongest predictor of vocabulary development, and children with ASD have more trouble acquiring a second language than children with just developmental delay, which is interesting. So this probably speaks to the core symptoms and disabilities within autism, that communication is one of them. But the take-home message here is caregiver communication in 2 languages to children with ASD does not have an adverse effect on language functioning. Encourage them, keep talking to your kid. Okay, case number 2. A 4-year-old with a diagnosis of ASD is brought in by parents for a routine well check. Overall, the child's doing well. Mother tells you the happy news that she's pregnant with twins. And you're like, oh my gosh, how are you going to do this? She's worried about the chance that her babies will also have autism and wants to know from you what to expect. Now, Gary talked a little bit about genetics. What do you guys want to say to this mom as she's sitting there with you? You're like, I am not a geneticist. What do I remember? Okay, so we talk a little bit about the prevalence of autism, which we've covered already. So the prevalence about, in 2 different studies, 1 in 59, or other national data suggesting 1 in 68, boys are 4 times more commonly affected than girls. 44% of children with a diagnosis of ASD have an average or above average IQ. This is really important for parents to know, that just because the kids have autism spectrum disorder doesn't mean they'll necessarily have intellectual disability. So encourage parents, because they're often afraid of getting evaluated because of that. 30% do have intellectual disability. The median age of diagnosis in the US is 52 months, super late. We can diagnose it around 16 to 18 months. So we'd like to move that needle back a little bit, particularly here in Seattle. Some of it is in the genes. It's heritable. The genetic test that is recommended if you do any is a chromosomal microarray. It can help identify the ASD risk genes and also may identify a diagnosable genetic syndrome. Gary covered some of this already. Identical twins in different studies have between a 60 to 90% concordance. Fraternal twins, 20%. Siblings are the same as fraternal twins. So for this parent, you can say you probably have a 20% risk that your next pregnancy has a child also with autism. Children born to older parents have increased risk of autism. And there are 2 drug exposures in utero that can contribute to autism risk. Thalidomide, which hopefully is not being used anymore, and valproic acid, which causes a host of other issues as well. Yes?
if you have a sibling who does not who has ASD but doesn't have an intellectual disability, does that have any? Will you
change the risk at all?
Yeah.
I don't know the answer to that question. I don't know if you know, Gary. Yeah. I think, as he said, that with intellectual disability, you're more likely to have a syndromic type of, so in that way, it probably does, but I don't know that there's any, I don't have any numbers to that. I had a couple of slides here, just if sometimes you get to be the first person to pick up dysmorphism. If you're seeing new arrivals to the country, you're seeing people who haven't had any screening previously. We talked a little bit about Fragile X before. 50% have overlap symptoms with ASD, avoiding eye contact, language delays, repetitive behaviors. 30% have a diagnosis of ASD. So even if you're taking care of a kid with Fragile X, you need to start thinking about some of the interventions that you could do to support their behavior as they get older and may meet more of these ASD type criteria. Trisomy 21 also has similar symptoms with ASD, and now we can diagnose both. Other things that are more common, tuberous sclerosis. These are just some pictures of some of the cutaneous stigmata of tuberous sclerosis, the periungual and facial fibromas, shade green patches down below. I guess I could use this. And then this is an ash leaf spot here shown under a woods lamp. You may not see it too clearly in a lightly pigmented person, but maybe more evident in more darkly pigmented people. 50% of children meet diagnostic criteria for ASD by age 5. Again, think about the therapies that you could put in place for these kids as they get older if they're in your practice. Oh, and then the only other thing there is that the intellectual delay and cognitive impairment are typically more evident if ASD is present in this disorder. So other things, these are just a little bit of zebra moments for those of you who take board exams from time to time. It's just for my interest. I'm going to breeze over this a little bit. Okay, so case number 3, a 2.5-year-old girl with ASD is brought in by mother for restrictive eating behaviors. She's always mouthed non-food items, a very common ASD trait, but at 18 months, she ate a pretty good variety of foods. Now she's down to only starches and chicken, nuggets, and grapes. She's not lost any weight by your measurement. So what are you thinking? Is this picky eating or is this a problem? Do you want to refer her? You want more information? We talked a little bit about picky eating earlier, but with Dr. Jones. But kids with ASD do not generally outgrow their picky eating. It generally tends to get worse. So if you're hearing a kid is picky, jump on it. Start doing something about it because a whole host of other things follow, right? You can get constipation, you can get anemia, all other things. So sometimes if it gets severe, like you're down to only 3 food groups, then you need to treat it like a comorbidity and actually actively manage it. You can assess sensory issues, food intolerances, allergies, constipation, reflux, behavior patterns. Just take a look. What are the things that are contributing to this picky eating? Other things in this. Recently, she started to grab handfuls of soil and eat them if she's allowed to go outside. Parents have had to restrict her outside playtime due to this behavior. I had one kid who parents would open the back door. She would run out, look at her parents, grab 2 handfuls of dirt and shove them in her mouth. She was driven to get to that soil. So, yeah.
Not so much on that specific bullet, but in terms of just the questions you might want to ask, a popular alternative treatment for ASD is gluten-free, casein-free diets. Mm-hmm. And if you have a child who's already got restrictive eating behaviors and then you're further restricting it, that would be of concern. So you want to assess for if they're doing any restrictive diets.
Right, if the parents are doing that anyway. And parents may be a little reluctant to tell you that they're doing that as well. Okay, so she's got some classic pica going on here. We talked about the oral feeding therapy already, so you're going to do probably a few labs, which may be a major issue, may not be, depending on the child. Sometimes it's really hard to get a good lab in the clinic. And then the issue is, what do you give her to correct the anemia of 9.2 that you find when you get the hemoglobin in clinic? We talked about constipation already. So the issue with iron supplements is they taste gross, and it's really hard to get kids with autism to take them. So fusion sprinkles is an alternate preparation. They are sprinkles that can be put on food, and generally are reasonably palatable, particularly if you can put them in a favorite food. They are not covered by Medicaid. You do have to write a prior authorization. Children can cover it. Parents can pay for it out of pocket, but it's not super cheap. Vitamin Friends is another one that's organic, vegan, gluten-free, kosher, checks a lot of boxes, and they actually taste pretty good. I've eaten these. We've gotten some in the clinic, and I have to try them, so they're actually pretty good. You can try. I have not had any success, even with a prior authorization. Fusion sprinkles will come up in most of your EHR kind of prescribing things. You're not going to come up with Vitamin Friends. Nor vitamins are halal vitamins, and so if in our neighborhood, we actually have a pharmacy that's covering them, that's carrying them, so I can tell parents to go and buy them. But that's some approach, some alternatives. Okay, last case. We'll do this really fast because I just got my 1 minute. A 12-year-old boy with ASD and increasing behavior outbursts, aggression toward mother and siblings. Mother's concerned that he's starting to go through puberty, and she is concerned for her safety as he gets stronger. This is where your heart drops into your shoes as a primary care doctor. You're like, what am I supposed to do about aggression? I don't know. So I'm not Dr. Kamenish, so tell me, from what you learned today, what would you do about this aggression? What are you thinking about at this stage in life and development?
I would also be evaluating for any other symptoms like ADHD symptoms at the same time, and then I would use my rating scales to see, where are you standing on he's 12, the PHQ-A, do a scared, and see what his core symptoms are, and then I'd pull out my handy dandy notebook, and I'd refer back, and I'd go, oh, you know what? No, I would pull out the PALS guide. Actually, I love the PALS guide. If you don't have that, get it. But seriously, it has some great guidelines, and then you could see what you think the most concerning behavior is. Are you going to start with some, Prozac or Zoloft, or are you going to look at Intune or guanfacine to try to calm down the behavior?
Or maybe what do we do first before we jump to medications too? I mean, this is a 12-year-old. What happens when you're a preteen? Okay, drug use, that's a good thought, yeah.
I think about Gary's slide and sort of the trajectory of social development, and this is kind of a prime range where they're falling further behind.
Right, I think 12-year-old is when they start to they get it in middle school. They're like, I am different from everybody else. And middle school is a super important time to be really similar to other people. And it's just really hard to be a 12-year-old and be different. Excellent.
What he's doing in school, because maybe he's being really aggressive at home with his mom and his siblings because he feels safe there, but at school maybe he's top notch or whatever, so I'd be really curious about that.
Good question.
I would refer him to some of the groups they have for kids who are neurodifferent, like the Ryder Center.
Yeah, what we'd call social skills groups.
Social skills groups, so that also he has some support or with people who might be sort of similar or have similar issues, and he could perhaps learn to deal with his aggression in a different way.
Yeah, great. These are all really great considerations. Yeah.
Well, in my practice, I find that oftentimes this is taken care of when relational tools change, or communication tools, and how the caregiver is responding to these behaviors and how they're responding to what happened before the escalation happened, and as well at school if adults can learn new ways to communicate with children.
Right. This is a classic. I mean, we know that there's special people who work with middle school age kids, right? There's a way of communicating and a way of relating that's super important. So all these are really great thoughts. Paul Carbone has done a lot of research on autism and primary care, and he has a great approach that I'm going to borrow from him and add a few steps to. One is ruling out a medical cause. Think of all those silent things. We think about constipation, reflux, joint pain, other injury that they may have received. Anything you can think of that a kid can't articulate but might be giving them chronic issues or ongoing issues. Get a really good sleep history. Is this kid playing Fortnite until 9:30 at night, and he actually needs 2 hours to unplug because that revs him up and he's falling asleep at 1? Make sure that there are no electronics in the bedroom. I mean, same thing you do with a regular 12-year-old, right? Make sure that their sleep environment is good. Consider caregiver stress, life transitions, what's happening at school, what's happening with his friends. Are people deciding they don't want to be friends with him anymore who were really good friends in elementary school? Like, what's happening? Consider behavioral interventions. So this is something that if the child has a behavioral therapist, bring it up. Start to talk about parental support, just like you were talking about. How does our interaction need to change to support these kids? And then go through your psychiatric comorbidity list and say, do any of these fit? Do I want to do any of those screeners? Do I want to figure out if he's had increased anxiety? Are we seeing a drop-off in his grades? Was he previously pretty high academic functioning, and all of a sudden we're seeing signs of depression and he's not caring about his work anymore? Just keep your primary care hat on there too. Call pals for great advice. And then create a family safety plan. Don't forget about the safety plan. This is really, really stressful for parents, particularly if there are other children in the household. If they feel like there is a toddler at risk or there is another child at risk, sitting down and taking the time to come up with a plan. When do you go to the ER? When do we get a courts team involved? When do we do something to make sure that you can keep your family safe? These are really hard, and we are definitely in the nascent phase of learning how to do these. How do you protect against suicide? How do you start talking to parents about putting sharps away, making sure medications are in locked cabinets, doing all those things that you do when you're afraid that somebody is